Hello, and welcome back to the Transformed Wellness Podcast. I'm Dr. Bradford Perkins, and today we're going to talk about one of the most common blood tests we do, the Comprehensive Metabolic Panel, also called a CMP. So, a Comprehensive Metabolic Panel is a panel of 14 tests, so some people call it a Chem 14. It evaluates your electrolytes and hydration, your kidney function, your liver function, your blood sugar, and protein status. It provides a broad overview of your metabolic health. There is another test called the Basic Metabolic Panel that only includes blood sugar, electrolytes, and kidney function. So what's included? You have your glucose, a test called your BON creatinine, that's looking at your kidneys, your electrolytes, your sodium, potassium, chloride, and CO2, which is bicarbonate, that's your acid-base balance in your body. Has your calcium, has your total protein, albumin, globulin. These are different proteins in our body. Includes then your liver test, the AST, ALT, alkaline phosphatase, and bilirubin. So when we look at glucose, the optimal range is 75 to 85 milligrams per deciliter. Less than 90 is preferred. This is way lower than what you're going to hear from your regular doctor, because if it's less than 100, they say, oh, you're okay. Prediabetes starts at 100, diabetes starts at 125. That's too high, because what's really the difference between 99 to 100? You're already right there going into prediabetes. So when glucose is high, we think insulin resistance, stress, poor sleep, or inflammation, metabolic inflammation. If it's low, that's hypoglycemia. That can be adrenal insufficiency. Those are your adrenal glands that make cortisol and other hormones. So from a functional lens, we're looking at your fasting insulin as well. I'm going to look at your hemoglobin A1C. There's a test called the HOMA-IR score that looks at your insulin resistance. Some people wear CGMs to monitor their sugar. And there's another test you can order called adiponectin that looks at what your insulin sensitivity is. So the more fat cells we have, the lower the adiponectin. So when we look at glucose, there's a 2004 study. For every 1 point above 75, there's a 1% increased risk of cardiovascular event. So that's starting at 75. So if you're 99, you're already 25% increased risk of cardiovascular disease, and you're still not quote unquote pre-diabetic. Then in 2008, there was a Kaiser study that showed for every 1 point above 84, there's a 6% increased risk of becoming diabetic in the next 10 years. So if your blood sugar is 94, you already have a 60% chance of becoming diabetic in 10 years. And then once your fasting blood sugar is over 90, there's already vascular and kidney damage occurring. And then there was a newer study, 2022, was done in Japan. Risk of diabetes increases by 9% for every point above 90. So if you're 99, you already have, quick math, 81% increased risk of having diabetes. So that's why understanding where you're at in making changes early makes a big difference, because you don't want to go into diabetes. That's more and more damage to your body. Your hemoglobin A1C reflects in your average blood glucose over 3 months. It's affected by glucose spikes after eating, red blood cell turnover, something called glycation. Pre-diabetes is usually saying 5.7 to 6.4, diabetes 6.5% or above, but really optimal is a lot lower. Optimal is 4.8 to 5.2%. So I do like to see 5.3 or less. Even 5.3 can reflect early glycation occurring in insulin resistance. And then an A1C may be normal, while the CGM shows major spikes in blood sugar after eating. So that's where a CGM is helpful, understanding what happens when you're eating. Insulin, often elevated years before glucose rises. So your optimal is 2 to 5. I've seen 2 to 6, maybe 3 to 6. But if it's over 6, it suggests early insulin resistance. Once you get over 10 to 15, that's high risk of cardiometabolic disease. I had people at 20, 30, 40, 50 and above. There's definitely severe insulin resistance that is reversible. There are treatments for all of this. Adiponectin, I touched on earlier. It's made by our fat cells called adipose tissue. it improves insulin sensitivity and reduces inflammation. However, as we have more adipose tissue, so as we gain weight, we make less adiponectin. So now you're gaining weight, more fat cells, and now you can't use the fat that's being stored because adiponectin is going down. So it's adiponectin's low in metabolic syndrome, high amount of visceral fat, that fat around our organs, and fatty liver. So it's inversely proportional to your BMI. So the higher the BMI, lower the adiponectin. Insulin, inverse. Triglycerides, if they're really high, adiponectin's low. And inflammation. So there's a test called the high sensitivity CRP. That's elevated. Adiponectin's going to be low. So your BON creatinine, this is your kidney function. BON should be about 10 to 16. Creatinine, 0.7 to 1.1. Now that can be thrown off. If you're taking creatine for muscle building and for memory, that's a different story. It's not true kidney damage. So if the BON's high, it can be because too much protein breakdown, but usually I see it because of dehydration. You didn't drink enough water before doing a blood test. Low BUN can be due to poor protein intake or the liver's not functioning well. So from a functional standpoint, I'm considering hydration, muscle mass. The more muscle we have, the higher creatinine, which is fine. Your adrenal status, how much stress you're under, and creatine use we mentioned. And you might need a different test called a cystatin C checked instead. Sodium, optimal range is 138 to 142. So if it's high, we think dehydration, sodium retention. Low, we think, we don't use the term adrenal fatigue anymore, but cortisol issues, low thyroid, and SIADH, that's a medical condition. So we want to check a cortisol and aldosterone if these are abnormal. Potassium, that should be about 4 to 4.5. If it's high, we think kidney issues, cellular breakdown, too much acid in the body, metabolic acidosis. Low, I think stress, people on diuretics, if your magnesium's low. So potassium loss often tracks with magnesium and stress, which is the HPA axis. Chloride, sodium chloride is what we think. It should be 100 to 106. If it's high, we think dehydration, acidosis again. Low, vomiting, anything that's because you're losing acid. Now your body's more alkaline. And then you have the anion gap. This is a calculation with sodium minus your negative ions. If you remember anything in chemistry, that's your chloride and your bicarb. So you want it about 8 to 12. But if your anion gap is over 12 to 16, we think lactic acidosis. Now that could be shock, sepsis. That can be uncontrolled diabetes called ketoacidosis. That can be renal failure. That can be toxins. But it can just be metabolic acidosis, anything making you acidotic, which can be metabolic acidosis related to metabolic inflammation. Low anion gap, if you have not enough albumin, or it can be a lab artifact if you're taking lithium. So functional medicine insight would be chronic hidden acidosis may be missed without reviewing the anion gap. So that anion gap's high, we have to think what's causing the acid. And usually that's oxidative stress and metabolic inflammation. So your CO2, also called your bicarbonate, we want it to be between 24 to 27. So if it's low, that's metabolic acidosis, lactic acid, ketoacidosis. High is metabolic alkalosis, so you're more alkaline, so from vomiting, certain diuretics, or it's compensating for issues with the lungs. Calcium, should be 9.2 to 10. It's bound to albumin. So if your albumin's low, your calcium's low, but that's just because it's bound. So if the calcium's high, you think hyperparathyroidism, these little glands hidden behind our thyroid gland. Increased bone turnover from metabolic inflammation. Low testosterone can also make high calcium, as well as cancer, unfortunately. Low would be vitamin D deficiency, or the parathyroid glands aren't functioning well. So you do want to look at ionized calcium, so that's unbound from albumin. And you want to think about magnesium, vitamin D, and vitamin K2. Your liver enzymes, first ones I look at is AST and ALT. Those should be less than 25. A lot of labs, that's still, even if it's over 25 is mark is normal. I have some labs where they think anything under 60 is normal. Remember, the normal range is 95% of people. But if most of those people are metabolically sick, we want to look at optimal. So if that's high, you think liver injury, muscle breakdown, or mitochondrial dysfunction. If the AST is higher than ALT, that's usually due to alcohol or muscle loss. If the ALT is higher, then it's insulin resistance, non-alcoholic fatty liver disease, which has now been renamed metabolic associated steatosis, MASD, disease. Your alkaline phosphatase, that's another marker. If it's elevated, you think bile flow, bone turnover, low zinc and vitamin B6. Bilirubin, you should be less than 0.8, but there are people that have genetic condition like Gilbert syndrome that's very high. That's that can liver detox dysfunction can lead to high amounts of bilirubin. And then from a functional focus, you think of how your body's detoxing, which is called phase 2, methylation. Do you have bile acids? You got to think of that when the bilirubin's high. GGT, I threw this in there. It's not normally part of a comprehensive metabolic panel, but this is a test related to liver. So that's why I wanted to put it here. So the liver enzyme that reflects bile flow, toxin burden, and glutathione recycling. And glutathione's our master antioxidant, that and melatonin. So we want to see the GGT less than 30 in men, less than 20 in women. So if there's over 35 to 40, there's some type of dysfunction. Is it alcohol? Is it toxin burden? Is it fatty liver? Is it gallbladder dysfunction? Is it chronic inflammation? Statins can raise it. Tylenol. So we've got to think about what else could be raising it. So this is a early warning sign of detox overload, and it correlates with glutathione depletion and mitochondrial stress. So we think got to support detox. Red blood cell magnesium. I did throw in a few other metals and here. So magnesium you want to check a red blood cell magnesium, not just a serum magnesium. This more looks at your stores of magnesium. So you think of it as the mitochondria, which is our power plant and metabolic stabilizer. You want to see optimal, about at least 5.7, 6 to 6.5. Truthfully, magnesium super safe. You can take a lot of it and not make yourself ill. But low red blood cell magnesium associated with insulin resistance, arrhythmias, migraines, anxiety, poor sleep, poor functioning in the mitochondria, and decreased ATP generation, which is our cellular energy. And 80% of Americans are functionally low in magnesium. So what causes the low magnesium? Low dietary intake, poor absorption, excess losses. A lot of people take PPIs, proton pump inhibitors like omeprazole. Alcohol lowers it. Insulin resistance does. Heavy sweating. So if you're exercising heavily, you need to take a lot more extra magnesium. Probably if you're an endurance athlete, you should be taking in about 10 milligrams per kilogram of weight of magnesium a day if you're training over an hour a day and sweating. High demand states can lower magnesium with chronic stress, high oxidative stress, and that can be from toxins and poor sleep. There's other causes. And mitochondrial dysfunction, that your power plant's not functioning. Pregnancy can lower magnesium as well. Red blood cell zinc. This is another important micronutrient. So you do want about 10 to 12.5. If it's low, you think chronic gut inflammation or leaky gut, poor absorption, having not enough acid. That's why the PPIs cause so many issues. If you have chronic illness or infection, you can have urinary losses due to stress, molds, and then it is antagonized by high copper or cadmium. So if you have a lot of cadmium exposure, which shockingly, when I do a lot of urinary heavy metal testing here in the Bay Area, that's, a lot of people do pop up mildly elevated cadmiums, which is interesting. And if you're overtaking copper, that's going to lower down your zinc. And vice versa. You don't want too much zinc because it's going to mess up with your copper. So there is a balance there. So, if we have high glucose, ALT is elevated, triglycerides are high, that's insulin resistance, fatty liver, metabolic syndrome. If your BUN's low, your albumin's low, your total protein's low, I'm thinking malabsorption, liver failure. If you have a high BUN creatinine ratio, I'm thinking dehydration. Could be a GI bleed, but that's usually in the hospital setting. In the outpatient setting, that's not usually the case unless they're coming in specifically for that. If your alkaline phosphatase is high and your zinc is low, you're going to have, that's telling me high bone turnover or the gallbladder is just not flowing. And if your sodium, chloride, and bicarb are low, I think adrenal insufficiency. So, some of those hormones our adrenal glands are making is having an issue, and it could be from stress. So, key takeaways is the CMP provides powerful insight into hydration, adrenal status, metabolic health, detoxification, and nutrient balance. You don't want to just chase individual numbers. You want to look at the pattern and the root cause. So it's a big picture. So liver, just like we said, the liver's high, the blood sugar's high, triglycerides are high. Then that's metabolic syndrome, and we need to think what's causing that. I want to thank you again for your time today. If you want more tips, subscribe to my channel. If you have any questions or experiences, please put them in the chat, and I hope everyone has a great day.